Alright, so today we'll be talking about the antidepressants, tricyclic antidepressants, selective serotonin reuptake inhibitors, and these monoamine oxidase inhibitors, MAOI inhibitors. I will talk about briefly, but I'm not going to spend a lot of time discussing these because they're really not used anymore. They have a ton of side effects, and there's some drugs that, especially the selective serotonin reuptake inhibitors, when they came around, they really replaced a lot of the other antidepressants. And then I've got a couple drugs on the atypical antidepressants that we'll discuss today as well. And here's just some examples. There's also some examples in your book. I would learn a drug or two from each of these, especially the tricyclic antidepressants and the selective serotonin reuptake inhibitors. On the MAOI inhibitors, if you just want to learn NARDIL, that's fine. And the atypical antidepressants, I've got a couple drugs, which I've listed in the PowerPoint at the very end. You may want to learn those. But I would learn a couple of tricyclic and a couple of your selective serotonin reuptake inhibitors. And we'll take a look at those in the book in just a moment. But some quick examples. The tricyclic is going to be amitriptyline and nortriptyline. But I don't see nortriptyline. Yeah, there's nortriptyline. Those are going to be your two most common tricyclic antidepressants. And then as far as your selective serotonin reuptake inhibitors, I'm not sure if one is more common than the other one, but we'll discuss those as we go along. Tricyclic antidepressants has in the past been the first choice. And it really was almost the only choice minus the MAOI inhibitors because of the side effects. But the tricyclic antidepressants had some side effects of their own. And it takes time for these medications to start working. They do not work immediately. So if you come into the office and you're depressed and put you on a tricyclic antidepressant, the next day you're not going to all of a sudden be better. You're looking at 4 to 8 weeks before you start seeing any effects from the tricyclic antidepressants. So it's not an immediate response that you're going to get from these medications. So if the patient calls you back the next day after putting them on a tricyclic antidepressant and they go, "Oh, I feel so much better, you should have put me on this years ago," they're probably just getting the placebo effect off that medication. The tricyclic antidepressants, they do inhibit the reuptake of serotonin and noradrenaline. So they affect two neurotransmitters. Everybody with me so far? I use treat depression. They do cause sedation more than the other antidepressants, specifically the SSRIs. Here's just a nice little picture of your, and this is also in your book on page 63, of your norepinephrine or serotonin. And we'll talk about this when we talk about our SSRIs. But if you notice, what happens is those neurotransmitters, if you're looking on 63, they're being released. They go into the synaptic cleft and into the receptor. And then after it does its thing, it starts to go back up. But when you take an inhibitor, for example, a tricyclic antidepressant or a selective serotonin reuptake inhibitor, it's going to block that reuptake. Do you see that little red X there on the little thing? So it's blocking that reuptake, so there's more of that drug available. This now is the most common antidepressant, and as I mentioned last week, depression is sort of the common cold of psychiatric problems. I hate to use that word, but and one reason why it's now sort of called the common cold is because the medication we have is more effective and less side effects than before. Selective serotonin reuptake inhibitors are considered the first line of therapy. So patient comes in depressed, and again, in here, especially me, I'm always about throwing drugs at problems. So when we throw a drug at depression, the drug of choice is going to be a selective serotonin reuptake inhibitor. The big thing here is that SSRIs are specific to serotonin. So the only neurotransmitter that they are going to inhibit is going to be serotonin. So if you want to look back at the little chart on page 63. So now we talked about figure 4-6, we talked about norepinephrine and serotonin. Now let's just pretend that it's just serotonin. So that serotonin is going to be released, and we'll assume that we're taking a selective serotonin reuptake inhibitor, such as, give me an example of one. A selective serotonin reuptake inhibitor, somebody? Fluoxetine, good. Somebody give me another one. So let's say that you take one of those. Now it's going to block the reuptake, so there's more serotonin available. Okay, so everyone's good with this? Used for lots of different things, depression, obsessive compulsive disorder, eating disorders, etc. Now with our selective serotonin uptake inhibitors, here we're looking at about a 2 to 4 week onset. Do you remember talking about isomers in Intro to Pharmacy? So Celexa and Lexapro are isomers of each other. Celexa came out, and when the patent ran off of Celexa, they found the isomer laying around on the desk somewhere. How convenient, right? And that happens to be Lexapro. So Lexapro's claim to fame is that it's closer to a 2-week onset of action. So, but we're still looking at 2 to 4 weeks before the patient sees any effects versus our 4 to 8 weeks with the tricycline antidepressants. Any other questions about our selective serotonin uptake inhibitors? Okay, so again, take a look at the chart on page 61, 62 at those selective serotonin uptake inhibitors, and be able to, if I ask you to give me a couple examples, make sure you're able to do that. I'm only going to briefly mention our monoamine oxidase inhibitors, again, because they're rarely ever used anymore. So I'm only going to mention a couple of them. They have a ton of side effects. So it was the first drug approved for the treatment of depression, so it's a really old drug. And if you look on page 63, figures 4-6, never mind, that's the mechanism of action of tricyclides. Oh, here we go. Excuse me, page 65. Oh no, that's the wrong one. Never mind. I thought it had another one for our... This is, okay. So never mind about the book. And it's going to affect several neurotransmitters. It's going to block the action of dopamine, norepinephrine, epinephrine, and serotonin. Remember in Pharm 1000, I said when we start hitting multiple receptors, that's when we start to have more side effects. So here, we're blocking a lot of neurotransmitters. So the chance of side effects is going to majorly go up. And again, there's a lot of side effects associated with these drugs. Also, there's a lot of certain foods that you cannot eat with this medication as well. Sort of the last note, used to manage the symptom suppression, not responsive to other therapies. Again, these medications are rarely used. Okay. Atypical antidepressants. So these are some that sort of fall in a special category, and there's a couple medications that I'll mention. On these medications, I would look over these and learn the ones I have here. I think I only have 2 or 3, so I would learn these specific ones. And they're going to affect the neurotransmitter levels, and we'll take a look at those specific neurotransmitter levels to those specific drugs in just a moment. And we can use these for bipolar, for depression, etc. One of the first things we'll take a look at is Wellbutrin, also known as Zyban, if you remember that. So the medication used to help treat depression and also to help people stop smoking. That was a big claim to fame for Zyban. A comment on this, it's something that you need to highlight if you have not already, is that there is a potential for it to lower seizure threshold. So you have a seizure threshold, and certain things can lower that seizure threshold. Stress, high temperature, high fever, alcohol, certain drugs. And when that seizure threshold is lowered, your body has the potential of having a seizure much easier. So with Wellbutrin, this medication lowers the seizure threshold. So if you have a patient with a history of seizures, this may not be a good choice to put the patient on. So make sure that you make note of that. It blocks the reuptake of dopamine and norepinephrine. So the two neurotransmitters that Wellbutrin affects are, go ahead, dopamine, norepinephrine, right? Okay. You'll probably see all this again. Okay, so that's all for that drug. Our next one is going to be Effexor. So this is another common drug used for lots of different things, depression, anxiety disorders, and this one affects serotonin and norepinephrine. And you can abbreviate these medications with abbreviations. You don't have to write you have to write out longhand, but make sure that you know. If I ask you which neurotransmitter does Zoloft affect, make sure you're able to put that it's a selective serotonin uptake inhibitor or SSRI. So you can abbreviate, but just make sure you know what the abbreviations stand for. Because I could simply ask you, what does SSRI stand for? And you would put selective serotonin uptake inhibitor. So make sure you can write it out, but you're more than welcome to use that abbreviation on things. Does that make sense? Mm-hmm. Okay. So again, Effexor is serotonin norepinephrine. Reuptake inhibitor, make note of that. See that again? The last bullet point I will not test you on, but I think it's just interesting, so I thought I would toss it in here. That 2007, Effexor was the 6th most common prescribed antidepressant with 17.2 million prescriptions. That's a lot of prescriptions. And that's it.